Okay, if I can have your attention. It is with great pleasure that I introduce for our Epidemiology and Public Health Plenary today Dr. Kate Shannon. Dr. Shannon is an Associate Professor of Medicine at the University of British Columbia. She's Director of the Gender and Sexual Health Initiative at the BC Centre for Excellence in HIV/AIDS. And she holds a Canada Research Chair in Global Sexual Health and HIV/AIDS. Her work on sex work is brilliant, I think, because it really connects community to research to policy and takes it through that whole perspective. And I'm really excited today that we have a chance as a group to talk about this because it feels like it's been a year or year and a half of both opportunity and missed opportunity with regard to sex work in Canada. As we watched the Supreme Court in the Bedford decision strike down Canada's laws on sex work, after listening to the experience of Canadian sex workers, after listening to research that's been conducted on sex work in Canada and elsewhere, we then watched our government, seemingly without paying attention to the same research and to the same lived experience that was heard in the court case, implement a new set of policies that, in my view, will likely see us back at the courts in the future as those get challenged again. So we're going to have lots of opportunities going forward to continue to have the discussion about sex work that we haven't had in the detail and in the depth and with the sophistication that we could have had. So Dr. Shannon today is going to talk to us about sex work, criminalization, violence, and HIV, drawing on her research in Canada and internationally. Dr. Shannon.
Good morning, and thank you very much, Greta and Sharmista and the CAHR organizers for inviting me today. As Greta said, it really comes at a critical juncture in Canadian policy as well as global policy really around sex work. So I'm really honored to be speaking here today about criminalization and some of the epidemiological evidence around how this links to HIV for sex workers. So I'm going to be speaking today initially around sort of the global epidemiology around HIV and specifically how that ties in with criminalization in the context of sex work, and then really focus the discussion in the Canadian context and some of our experiences, lesson learned, and definitely our challenges in terms of knowledge translation in terms of some of the research in the Vancouver context in particular. So just before I begin, my conflicts of interest. So in terms of global burden of HIV, we know that sex workers continue, as with other key populations, to be really disproportionately affected by the HIV pandemic. In terms of overall pooled HIV prevalence among female sex workers in low and middle income countries, female sex workers continue to be 13.5 times more likely than women of reproductive age in the general population to be living with HIV. And when we look at across a map, we see that certainly in areas with the heaviest HIV burden and in generalized epidemics, these numbers are even higher. So certainly in sub-Saharan Africa, Eastern and Central Europe. When we add in higher income settings, as you can see, there's significant areas with white, which really reflects a lack of actual surveillance and epidemiological data. So North America is certainly both Canada and the US do not have sufficient data to actually look at overall HIV burden, but we do know from studies from specific settings that certainly HIV is significantly higher among female sex workers than the general population. There's really even less data when we talk about male sex workers and transgender sex workers. In 2011, there was a review and meta-analysis among 51 countries with available data among male sex workers that found HIV prevalence among 4 countries to be higher than 25% and among 12 countries to be higher than 13%. When we move to transgender women sex workers, there's even less data, so there's only data from 14 countries, but there we see significantly higher rates, so 27% higher among transgender women sex workers than transgender women non-sex workers, and those rates are 5% higher than female sex workers. In terms of the global epidemiology of HIV and the response has really continued to be framed and hampered by criminalization and punitive approaches from the early stages. So in 2007, when PEPFAR was introduced as part of the Bush administration, that came along with an anti-prostitution pledge, which I'm sure many are very aware of, and has only very recently been retracted in context through litigation efforts. And this anti-prostitution pledge essentially hampered ASOs, community organizations, organizations, sex work organizations, from taking money for in the HIV response, large pockets of money, particularly in lower middle income countries, unless they explicitly signed on to the prostitution pledge and agreed to eradicate prostitution. So this had direct effects, certainly in Uganda, where I've been working, collaborating with some colleagues. It really directly affects on the ground how ASOs could respond and work with sex workers, as well as how other community organizations could access funds. Another piece that I think is really important in framing how public health response, the scientific response, has been framed from the early stages is that certainly sex workers from an early stages were really framed as vectors of disease and moral contagion, and the sort of early epidemiological literature certainly did a similar context in terms of framing sex workers really as the vectors of disease, often forgetting to really even consider or frame how clients and partners played a role. So these are early posters and campaigns that sort of syphilis and gonorrhea, she may look clean, but pickups, good time girls, prostitutes spread syphilis and gonorrhea. And these are posters by the Center for Disease Control in the US. So I think it's really important because I think that also framed a lot of early partnerships and work between researchers and sex workers given this historical context. So in terms of what do we know in terms of global epidemiology of HIV and what factors are linked to increased risks of HIV, certainly there's early work that has really shown and continues to show the importance in terms of behavioral and biomedical factors, but I think they also show the limitations in terms of the need to move towards more combination prevention, including structural and community-led approaches. And that's really where I want to talk today in terms of some of the evidence. So among 204 studies between 2008 and 2013 that were reviewed, or any available data that had HIV or condom use as an outcome, the majority were from low and middle income countries, which really showed a disproportionate amount of data drawn from Asia, and particularly a few countries within Asia, and huge gaps in science in terms of evidence in sub-Saharan Africa, Eastern Europe, and Russia. So where the heaviest HIV burden, we're seeing really limited data in these contexts in terms of epidemiology. And often this is directly a result of the same structural conditions that are putting sex workers at increased risk for HIV. Among the published studies, less than 50% looked at structural determinants, and that's where I'm going to turn and talk about what those structural determinants are and what we know. But certainly given the centrality of structural determinants from an HIV response and what we've seen, it is significantly a strong concern that we really don't see a lot in terms of the data. So in terms of what those structural determinants are and what available evidence there are, at the macro level, structural determinants, that factors that have been linked to increased HIV prevalence or incidence or to reduce condom use include a range of factors, but strong epidemiologic evidence certainly around criminalized and punitive laws, stigma, food and residential instability and insecurity, as well as gender inequities. So studies have examined factors of gender inequities and sex trafficking. At the same time, factors that have been shown to mitigate HIV risks for sex workers through epidemiological literature include gender empowerment, higher education, and literacy. There's also certain factors such as migration and mobility that really have fairly complex and nonlinear relationships with HIV risks for sex workers. So in some cases, for example, internal domestic and circular migration has been linked to increased HIV risks, but we've also seen migration from non-endemic HIV settings to be associated with reduced HIV risk for sex workers. Other factors that have been shown to play an important role in terms of HIV epidemics globally for sex workers is community organization factors. And certainly there's growing research to suggest that community organization and community empowerment factors can shape reductions in HIV risk at both a population and individual level. However, this data is largely restricted to India, with only a handful of studies from a few settings, including Kenya, China, Central and Latin America. And this is largely given a huge investment by Bill and Melinda Gates Foundation within India, which has allowed for both large scale-up of community empowerment as well as large-scale evaluation of those efforts. So speaks to a lack of resources really globally in many other settings to evaluate grassroots sex worker efforts. But I think it also speaks to limitations, funding restrictions, criminalization that actually hamper sex workers' ability to really scale up and organize. And certainly we've seen that in Eastern and Southern Africa. Other factors at the structural community level that really play into, from an epidemiological perspective, are linked to increased increased HIV risks and reduced condom use are work environment factors, and these can be a range of physical, social, policy, and economic features within the work environment that shape HIV risks. And existing data has particularly shown that physical and sexual violence within the context of sex work, so this might be clients, police, exploitive third parties, strangers, are consistently linked to increased HIV risks. Also policing and law enforcement strategies, and these range from lawful to unlawful within the context of a criminalized model. So they may be displacement and forced displacement given current laws restricting work on the streets, or they may be unlawful in the context of excessive use of force. There's also a fear of policing and threat of policing that continue to be linked in epidemiological studies to increased HIV risks. Suboptimal access to safe, appropriate sexual health and condoms and an HIV cascade of care continues to play an important, continues to be consistent across settings, and we see it both in generalized and concentrated epidemics, and really linked in studies to increased HIV prevalence in settings as well as reduced condom use. And another factor is economic pressures for sex workers. On the flip side, what we do see in terms of successful factors that have really helped to mitigate HIV risk, both at individual as well as population level, is supportive work environments. And what that looks like is a range of, it really is context specific, but there's certainly a range of examples from Southeast Asia in particular, Philippines, as well as Dominican Republic, some examples in Brazil, of environments where supportive policies and features, so that may mean access to condoms on site, access to HIV testing on site, that may mean supportive managerial practices. And often it's several of these factors working fairly synergistically to increase sex workers' ability to negotiate condom use with clients and reduce other risks such as violence. And I'm going to be talking today specifically about an example in the Canadian context where we've certainly seen this. Other factors include higher sex work income and lack of economic dependence. We also see at an international level that there's been some significant progress in terms of policy guidelines that have really framed the importance of law reform within the context of the HIV response. So these were guidelines launched by WHO and UNAIDS bodies with the Global Network of Sex Work Projects in 2012. And they were focused on the prevention and treatment of HIV and STIs among sex workers in low and middle income settings. And decriminalization was really clearly articulated as a cornerstone in terms of the HIV response, and I think was the first time there have been really strong guidelines marrying public health and human rights in terms of the HIV response for sex workers. There's also been some more recent efforts looking at the Global Commission on HIV and the Law and their recommendations around sex work, which also clearly articulated similar response, but have also gone another step further in terms of really looking at what has been a consistent move across much of Europe, and we're now seeing in Canada, of an approach towards criminalizing all aspects of the industry, but not sex workers, and the need to address that in terms of evidence base. So I want to shift now to talking a bit about the Canadian sex work landscape, or in terms of legislation, in terms of advocacy, and then really specific examples of research and evidence and sort of lessons learned as well as challenges in terms of knowledge translation. So these are one of the sex work groups, Sex Workers United Against Violence, who was part of the Charter Challenge or, in the Canadian context, as well as intervened at Bedford. And it was certainly one of our close community partners. So in terms of criminalized sex work laws in Canada, for those that don't know, as a brief sort of synopsis, I think Greta spoke about these, but certainly the laws were struck down in 2013, and the laws and much of the evidence I'm presenting today was in the context of that sex work legislation, which essentially criminalized most aspects surrounding sex work, but not the buying and selling of sex. And what we continue to see and have seen over the last 2 decades is really both intended as well as unintended consequences of those laws in terms of the health and human rights of sex workers. And these are some of the sex workers' narratives and lived experiences in terms of how those laws were impacting. For those that can't see at the back, I hear about so many women who've been infected with HIV during a bad date or been raped or molested or something like that, you know, and these people, they get away with it. And a lot of discussion around the complete lack of response that government and policymakers are had on sex work and the huge number of missing and murdered women, and how that really has direct effects in terms of sex workers' ability to negotiate safer sex, as well as a range of other health and social protections. I think it's also important to mention that in the Canadian context, there were 3 separate parliamentary subcommittees that all had similar responses or conclusions in terms of the status quo in Canada is not working, and that's over the last 2.5 decades. But in each case, the government of the day failed to actually take these and frame them in terms of action, and which has really ultimately led to where we are today, and to sex workers having to take these constitutional challenges to court. And in 2007, 2 separate charter challenges were launched, one in Ontario and one in BC, and the one in Ontario is the one that ultimately was the Bedford case heard at the Supreme Court of Canada. So in terms of the research within the Canadian context I want to talk to you about, much of it is framed around a project and evaluation of sex workers' health access, or AHA, is a longitudinal cohort that was initiated in 2005, and we expanded in 2010 to 800 street and off-street sex workers. A range of community partners we've been working with, and a lot of that's been really critical to our ability to respond to relevant issues on the ground, but really to make sure that epidemiological research as much as possible is framing some of those public discussions and policy discussions. Similar to other epidemiological work in terms of ongoing cohorts, so we have a longitudinal component where we're ongoing interviewing every 6 months, but also a qualitative and ethnographic component. And I think one of the things for us in terms of lesson learned of the ability for epidemiology to really be translated is the critical need to work together with qualitative and ethnographic work to really frame and respond to. And I think we also saw that later on in terms of our capacity in terms of knowledge translation. And our overall goal is fairly broad in terms of evaluating the impact of evolving individual and social and structural factors on a range of outcomes, including HIV and sexual health. And I wanted to also just mention that in terms of framing of the cohorts, I think for us, in terms of what's been able to be responsive, and it has also been our ability to do ongoing regular outreach and the ability of research to actually on the ground essentially have a I wouldn't say a service component, but be able to be regularly connecting with the community and as responsive to the current issues. So we have a lot of our recruitment and ongoing outreach is done through both street and off-street outreach to the community. So in terms of the key findings, HIV prevalence within Vancouver really has significant heterogeneity, similar to what we've seen globally by work environments, and really what we've seen specifically street-based sex workers and informal indoor sex workers have the highest rates in terms of HIV. So we currently within Vancouver, we see about 20% within informal indoor sex work, so that looks like bars, hotels, sex workers primarily working the street at about 14% in terms of living with HIV, and significantly lower, so 4 to 5% among sex workers working in more formalized environments. In terms of what that evidence looks like in terms of factors linked to increased HIV and STI risks, we had a range of papers that really looked at how HIV criminalization is linked to increased risks for violence, as well as increased risk for HIV. And this is 2 papers summarizing kind of those range of epidemiological evidence of how criminalization and policing increase both HIV as well as violence risks. We've also seen, since much of the debate had really framed around, decriminalization or criminalization of adult sex work, I think much of the push and the public discussion ends up actually being around exploitation and a conflation of those two. We were able to look, this is a paper led by Shira Goldenberg that looked at how early sex work initiation, so underage sex work, among adult sex workers was linked to increased HIV infection among sex workers when they're adults. It was also increased rates of police arrest for prostitution charges. So what that means is those most vulnerable, sexually exploited and working under age of 18 were actually the most targeted by a criminalized model targeted at adult sex work. So the laws are not only failing adult sex workers, but we're also seeing repercussions in terms of marginalized youth. We also have some evidence that really looked at the client demands for unsafe sex. And again, what we see is if you're working in more indoor work environments, sex workers were more able to not take more money for unprotected sex, and that was a range of several analyses looking at both offering and accepting more money for condom use, and really saw that both where violence and street-based sex work was highest among street-based sex work was associated with higher rates of accepting more money for unprotected sex. We've also seen a number of studies where we've been able to map how displacement and policing really push sex work to more isolated and hidden spaces, both street and off street. This was a spatial isolation index that tried to look at the city data to where there was lighting, where there was access to main streets, and how spatial isolation was directly linked to increased risks of both sexual and drug risks for sex workers. And this is certainly consistent with what we heard through a lot of the community groups, and I think really echoed from an epidemiological perspective how this plays out in terms of HIV and STI risks. Another piece we saw in terms of how the current criminalized laws have these sort of unintended consequences is that by criminalizing sex work, it gave broad latitude and gives broad latitude to managers of housing programs within low-income housing in terms of targeting more marginalized groups. So in this case, it was sex workers speaking about how either guest fees or curfews meant that sex workers were not able to bring clients indoors to their own rooms, which I think is an important contrast to people living in higher apartments in sort of non-low income contexts where they can bring whomever into their room, there's no context. And while that may seem trivial, it's really critical in terms of sex workers' ability to work indoors, to have their own access to safety protections, and also has led to a significant amount of ability of managers and clients to actually evict sex workers for working. So this ends up being further trivializing, marginalized the most marginalized women and potentially men and transgender individuals within the context of sex work. We've also seen that stigma of sex work, so fear of disclosing sex work status, given the criminalized model, has direct impacts in terms of primary health access. And we have a new analysis that's not here that also we found that has similar in terms of willingness to disclose to providers to access regular HIV and STI testing for fear of disclosing their sex work status. So in terms of our initial KT approach, I think initially was more of a broad sort of range of media trying to dissemination, but I think increasingly what we've seen is that where we can have most effect in terms of public discussions has really been with partnering with community and ensuring that the media translation includes both sex workers and the researchers in communicating some of those results, especially where it's epidemiological evidence that is hard to necessarily translate in a context of community. And that's really where we've been able to get the most traction in terms of those conversations, along with sort of working with policy and legal experts in terms of framing that discussion through the media. I think this poll is important to frame that in terms of lead up to Bedford, there was already a strong consensus within Canadians that the current status quo wasn't working. What I think then led to was a lot of missed opportunities in some ways in terms of public discussion before we got to where we're at now, which is a significant step backwards from the Bedford case. So I want to turn to two examples in terms of how I think epidemiology and research generally can look at naturally occurring experiments, naturally occurring population health interventions, and evaluate those through longitudinal efforts to really help respond responsively or be responsive to emerging policies and community approaches as they emerge. And the first example is more on a community approach, and the second is more on a policy approach. And I also think we learned a lot from the first approach in terms of the limitations. In the first approach, it was exclusively qualitative, and then we did a second quantitative or epidemiological component after, and I think as a result had a bit less traction in those discussions. So these were housing models that this initial paper, the title actually had the word brothels in it, and that was based on our community discussions. These were housing programs in Vancouver operated by Atira and Rain City that are low-income housing for women and had developed supportive policies for sex workers. So clients had to sign in at the door. There were bad date sheets and condoms and resources on site. They had street nurses coming in for HIV and STI testing for sex workers, and they also had regular communication in terms of police. And initially were actually approached by community to be part of the legal challenges, but felt that it wasn't about a stance on sex work so much as being a very harm reduction model for sex workers. However, once we started doing some qualitative work and approach them, we said, this would be really critical evidence to get out there because it needs to debunk that myth of what a brothel is and what it looks like in terms of how that can increase sex workers' ability to negotiate condom use and reduce risks of violence. So these are some quote narratives from sex workers talking about how these various factors, camera surveillance on the main areas, bad dates, allowed sex workers to safely negotiate condom use in their rooms, knowing that their managers were on site, would call police if there was violence altercations. It also meant they had access to condoms, which continues to be a challenge in other settings where sex workers are working much more covertly. And that improved relations with police, which I think was really important, especially in the Vancouver context, where there's been such a distrust with police and health protections. When we initially released this work, we worked really closely with provincial medical health officers to ensure that as much effort had been made up front to make sure that this didn't have any negative repercussions for community groups. That included briefing the chief of police, the health and housing ministers, as well as the mayor, and trying to make sure there was as much, I guess, traction in terms of community wanting to make sure that there was no negative repercussions for women living in these housing programs. And I think the first day, the narrative was essentially indoor sex work is safer, and it seemed the second day there was much more media focus on the legal implications of that and what there were titles of, brothels leading to HIV risks. But I think what was important is that the health and housing, or in this case, the housing minister is actually quoted saying, I'm not going to throw anyone under the bus. I'm not closing these programs given what they're doing. And I don't think had we not given a heads up, we would have had that same response. The downside was, and where I meant about the qualitative or quantitative, is that because it was explicitly qualitative, what did happen was it was discounted as those narratives of 40 or 50 sex workers, and I'm sure does not necessarily speak to what about all the other people. And so the next time we were in that position of looking at evaluating policy, we were really careful to have as much different armor as possible in terms of evidence and lines of inquiry to make sure that we were really able to speak to it at a broader level, at an individual level in terms of sex workers' experiences, as well as at a policy level. And sorry, I should have mentioned that we then were able to submit that to the Supreme Court. We ultimately followed that up with more quantitative epidemiological evidence looking at a scale of safer indoor work models and how that was linked to increased consistent condom use for sex workers through a range of harm reduction and sexual health access, managerial practices, so as I mentioned, the client sign-in, resources on site. And I think it's important because some of these examples have been really highlighted in lower and middle income settings, but they exist as a regularly occurring intervention across many settings in higher income settings, just have not been evaluated. Ultimately, a lot of this evidence, we partner with the Canadian HIV/AIDS Legal Network to intervene in the Bedford case and bring forward as much evidence that we had as possible in terms of peer review literature. And particularly, that was the HIV Coalition, just focusing on how the evidence was linked to HIV risks. And this was just a summary sort of highlighting the key factors, so policing and displacement, violence, and how those various different narratives and dynamics shaped HIV risks for sex workers. And as we heard from the beginning, ultimately a strong decision by the Supreme Court that was followed a year later by a very backward steps by our government. So the other example that we looked at in terms of how we can use research and epidemiological evidence to really evaluate population health interventions was an evolving police department. And Vancouver has actually been on the spectrum, fairly progressive in the sense that there's been some really great dialogue between sex workers, police, health providers, and there's including a task force, as well with the Missing Women's Commission inquiry that really led to police taking an official policy to not harass and target sex workers. What was really important about this is that it was in the leading up to of C36 and the new laws that Harper government has put in, which criminalize sex buyers, so to specifically target clients. This was actually an example in Vancouver where it was already being piloted 2 years before. The Harper government was probably more than aware of this, but I think it was kind of left undiscussed. And at this point, we really wanted to be able to evaluate and say, look, it's already been piloted in Canada. We can't keep saying, oh, we don't know how it'll work, let's try C36. We have evidence to strongly look at this. So in this case, we were able to look at epidemiological evidence of prevalence of sex worker, of violence and various other health indicators before and after the policy implementation by police. And then we looked at police-owned data. So we were able to look at publicly available police arrest data on prostitution charges before and after the policy to see if the arrests went down when they stopped targeting sex workers. In fact, they went up. And we actually then were able to call the police before we put out our media release and press conference was to call and confirm with them that, in fact, yes, the arrests have been largely increased beef targeting of clients, which is what we're probably seeing as C36 evolves right now. In terms, we also had qualitative narratives from sex workers, which was equally important to really highlight how those laws were having similar repercussions or similar impacts as what we'd seen in the lead up to and the laws that had been struck by the Supreme Court. So a lot of the same narratives that we heard at the Supreme Court by sex workers, by experts from public health, research, and legal experts was that the laws reduce sex workers' ability to screen clients to negotiate transactions, displace sex workers, and reduce access to critical police and health and social protections. And really, what we saw was no difference in terms of that narrative, because so long as one aspect of that sex industry being targeted, sex workers had to work in more isolated spaces, rush transactions so they couldn't negotiate condom use, and as a result, were at increased risk. And there's a quote by a sex worker here that says, harassing clients is exactly the same as harassing the women. You harass clients and you're exactly the same spot you were before. In terms of where we were able to take sort of what had worked and what hadn't worked in our initial sharing of the responses housing, we did a community report that was partnered with SWAV, the sex workers group, and Pivot that looked at a constitutional analysis of the research, so looked at all the different levels of evidence and then did a constitutional analysis of how that would stand up. We then shared it with all the MPs and government leaders, and then as well through the media. I think what did work better was having the range of evidence, but ultimately I think one of the challenges we continue to face is how to really engage with policymakers at the federal level, certainly, but in terms of actually making sure that evidence has some traction. In a similar vein, we were able to do an academic open letter, which many colleagues here signed onto, that was calling out the concerns of the Swedish models, which is the so-called criminalizing of clients, given the concerns in terms of health as well as human rights for sex workers. And I think was another way that academics can mobilize and speak to the science and how that science is impacting on a policy level. And try and get that discussion going in a public domain. Ultimately, obviously, C36 was passed with little ripple effect, and despite lots of effort by community, by academics in terms of speaking at the Justice Committee, Senate Committee, this evidence really had little effect. And I think that's really where we've hit a lot of challenges, is watching what will likely be another 7 years of Supreme Court case to really tackle the current laws. And this is sex worker groups that put on masks the day C36 was passed, saying not criminals, not victims, and the chair of the Pivot Board, who's also a sex worker herself, speaking to the impact of these laws. So turn in terms of how, in terms of way forward and I guess opportunities as well, and I think this came actually on the heels of a lot of what was happening in the Canadian context, was the Lancet released last year a large series on sex work and HIV at the AIDS 2014 meeting. And the first paper, which I had the opportunity to work with colleagues both in Global South and Global North, and included a mix of academic experts as well as sex work experts to look at the global epidemiology, but really the focus was to model how structural interventions could impact the course of epidemics across a range of settings. And we picked 3 settings that were sort of show the heterogeneity of the HIV epidemic in those contexts. So one in Kenya, so looking at sort of more of a generalized high prevalence epidemic, another in India where there's been significant progress, and then in the Canadian context. And what we saw was that across all those settings, because of the iterative effect, and we were able to take context-specific data of policing, violence, workspaces, and then rates of condom use, STIs, HIV within each setting, as well as access to care, and look at how some of those structural factors, if we change them in the course of the model, could impact the epidemic over the next 10 years. And ultimately, the narrative, which really ended up getting the one narrative that was carried, is that decriminalization, through its iterative effect on violence policing, can have the largest impact on the course of the epidemic. And that's really because of the iterative effects of condom use policing. And I think it also really, for us, highlighted in terms of where epidemiology and social epidemiology really can move, is to really look at much more complex models and narratives, or complex models and dynamic models where factors are not so linearly associated with factors. And I think some of the limitations of what we've seen in some of the epidemiology to date, including our own, has been how to really tease out those factors at a multi-level and more complex context. We also included some narratives, again, really trying to highlight the importance of making sure the lived experience is documented while putting out these large, kind of sort of more complex discussions and analysis, is to, and this was a narrative or a quote from a sex worker and lodge owner in India that spoke to how safer work environments, so not dissimilar to the Vancouver context, can really be protective against HIV and ensure that sex workers have access to and can safely negotiate condom use. In the heavy HIV burden context within Kenya, what we saw was that access to treatment to meet the WHO guidelines of CD4 or less than 500 could have a substantial impact on the epidemic, particularly where access to ART meant for sex workers and clients. We also saw that sex worker-led outreach, even modest sex worker engagement, could have a substantial impact in terms of averting up to 20% of infections over the next decade. And then similar to our context in other settings, again, a policy reform remained to have over, in this case, 34% potential impact in terms of averting HIV infections over the next decade. I think what was important in terms of context and where we didn't have the data epidemiologically and we really need to draw from the qualitative experiences was that there's, as I mentioned, really little data in terms of structural determinants and epidemiology around structural determinants in a lot of sub-Saharan Africa, and it's been great to actually see in last year an increasing number of studies coming in that from sub-Saharan Africa in that context, as well as some of the other heavy HIV burden settings. But what we didn't have data at the time to say is that, how are these factors, how would ART access, if that was just, if we just scaled up ART access on paper, it looks like we could have a huge impact. But at the same time, what we're hearing qualitatively is a denial of health services and direct denial of ART for sex workers. And some of that's historical and stems from PEPFAR, some of that stems from other cultural and legal barriers in the context, and some of it stems from direct efforts towards criminalization in settings such as Uganda. In this case, a sex worker talking about, well, I fell sick, I went to a health center and they realized that I was a sex worker. They did not treat me like a human being. I was told that they had no time for me, so I left without getting treatment. And that narrative is not dissimilar to many narratives we've heard in terms of sort of denial of ART and denial of HIV testing and treatment within the context of sex work. So ultimately, this was launched at the AIDS 2014 meeting, and I think what was great is that in this specific case, it was the first time the Lancet actually had a community member as one of the editors. So one of the editors was both a sex worker as well as a researcher herself. So I think that was really important in ensuring engagement with community as well as co-authorship on the papers. And while I think we were able to have some traction and input in terms of media across a range of countries, I think really what's the next step and that needs to be, and there's lots of discussion, is how do we actually have regional impact with those narratives on governments and discussions that are happening. And I think there's still a lot of work that could be done there. The other piece in terms of really just where I want to end with is that I think the important piece of that Lancet series and similar series that have been for other key populations is calling out a bit of an action agenda that gets buy-in, so has co-authorship from the director of UNAIDS and other major policy people to say that we really need to move. Combination prevention really needs to include a structural approach, needs to include a community-led approach in ensuring that when we're talking about suboptimal access to treatment, we're not just talking about scale-up and coverage, we're talking about those structural factors, those community factors that really play into whether or not access actually gets to the hands of affected populations and whether that's safely and voluntarily. The other piece, and I think that was really interesting from the series, was there was efforts to debunk the myths in terms of sex work. And I think some of these myths are actually perpetuated by early research. So in this case, some of the myths are, all sex workers are women, male sex workers are all gay, transgender sex workers have the same rates of HIV as male sex workers. And I think some of that came out of, for example, in the transgender sex workers, when we started to review the data on male sex work, seeing that a lot of the time researchers don't have the power or don't have the ability to, sample size or power or access to include enough transgender sex workers to really desegregate data. And so as a result, that gets lumped in with male sex workers, and we get really, we don't get a clear picture of how the epidemic looks. So I think there's a lot of capacity for research, as much as it's inaccurately perpetuated myths, to really debunk some of those myths in moving forward. So I just want to end with acknowledgements for a huge amount of people that have really been instrumental, particularly in the Vancouver context in terms of the CAHR project, our advisory board partners and collaborators, as well as funders. So thank you.
Hi, thank you very much. Joel Kettner from Winnipeg. This might be influenced by Galit's talk just before you, but I'm wondering about the susceptibility side in addition to the exposure side. And what do we know about the heterogeneity amongst sex workers with regard to risk for HIV infection related to socioeconomic status, nutrition, how much sleep they get? I think sleep was someone that Galit mentioned, that it affects the immune system, mental health, comorbidities, all of these things. And from a biological or a socio-biological point of view, that might also relate more to underlying determinants in addition to all of the exposure issues that you so very well brought to our attention.
For sure. I mean, I think that's an important question, and not being a basic scientist, I don't want to go into the specifics without probably completely butcher what, but there's certainly critical evidence from Kenya in particular among sex workers who've actually, been repeatedly exposed and unaffected that have been really important. And I think where there aren't gaps is a dialogue between some of more of the basic science, molecular epidemiology, and sort of the social epidemiology. And so I think, we don't know a ton about that picture still. We do, from a biological perspective, there's been great progress, but I think there's more that needs to be done to look at how those intersect in terms of susceptibility and transmission. So certainly a lot of those factors, I think, speak to both a transmission as well, a risk in terms of both acquisition and transmission. But I think a lot of the epidemiology has been pretty linear in terms of what it's looked at. We also see a lot more cross-sectional data, especially in this context, and often that speaks to, outside of Kenya in a few places, Rwanda has some there are not a lot of longitudinal cohorts, and sometimes that speaks to where there are, it's, sex workers who are being followed in treatment, so it's not a broad picture, and so we don't know, how that plays out for sex workers who don't have access to care, who aren't engaged. So definitely opportunities for where I think things could go, yeah.
Okay. Well, on behalf of the organizing committee, I'd like to thank you.
All right, thanks very much.
Thanks.